I might have clicked on a button I shouldn't.
All right. Hello, everyone. I hope you've connected successfully. If there are any problems, let us know. My name is Camila, and along with Eloisa and Amy, I am representing the ISPOR KI Student Chapter. Today, we're joined by Filipa Sampaio. Filipa is a health economist and a postdoctoral research fellow at Uppsala University in the Department of Public Health and Caring Sciences. She holds a Master of Science in Public Health and Health Economics from Karolinska Institutet, and she has a background in nursing. Today, the topic is child mental health. Filipa will give a brief introduction on health economics and present the work that her research group has conducted in the field of child mental health. The talk will last for about 15 minutes, and we will have time for questions at the end. If you have any questions during the talk, please put them in the chat, and we will make sure that they are answered. Welcome, Filipa, and thank you for joining us.
Thank you, Camila, Eloisa, and Amy for having me here today. So the talk is supposed to last for about 20 minutes, and I've prepared a few slides for you that are, I'm just going to move on to the next slide. Sorry. So that are basically divided into a short introduction to health economics and economic evaluation, given that the audience is supposed to be quite broad, and maybe some of you haven't actually you've heard about health economics and evaluation, but you don't know a lot about it. Then there's a little section on child mental health and the importance of investing in child mental health. And then I've prepared also 3 examples of our work in the field of child mental health, and this being within trial economic evaluation, a model-based evaluation, and a cost of illness study. So going to make more sense to you that aren't really sure what these things mean in a short while. So a brief introduction to who we are. I realize I actually put a very small photo of us, but we're 4 researchers in health economics, part of a research group at Uppsala University that is called Child Health and Parenting. We're at the Faculty of Medicine. We're about 25, 26 people. We're self-funded, so we get money from grants, public grants. The main business of us 4 is economic evaluation, such as trial-based, modeling studies, register-based studies, cost of illness studies. We also do systematic literature reviews, and so on. And our main research streams are mental health, child health, and public health. We're small, but we're mighty, as one could say. So briefly about what economics does. So economics addresses the fundamental issue of allocating scarce resources between competing demands. And because demands for healthcare services is growing rapidly, even more rapidly than what the healthcare systems and society can actually are able to provide, and also the available resources, then we need a way of optimizing those resources and making sure that they reach the people that need those resources, and that they provide the most health possible for the population. And this is where health economics comes in, that health economics applies principles of economics to healthcare with the goal of, as I said, maximizing health, so benefits from available resources. And health economics has 4 main tasks. So one of them is called description. And these are studies that describe current health status, current resource use and related costs, current activities, and examples are burden of disease studies and cost of illness studies. Another task is prediction, where they predict future health status, future resource use, future costs, and the goal is to inform on the size of problems and help set funding priorities. Another area is the explanation area, where these studies, they try to describe trends and determine key influences on health status, for instance. These studies, they are this is not the bulk of health economics, and there are a few studies, but not all of them are able to infer causal inference between several risk factors and health. And then there's the task of evaluation. And this task aims to determine the benefit of interventions relative to their costs. And this is the only task of health economics that actually help determine value for money. So health economic evaluation aims then to compare relative costs and consequences of different interventions to answer the question, is investing in a certain intervention or program or drug or medical device or solution value for money? It aims to inform decision-making on the best way of allocating scarce resources. Then I'd like to talk to you about three key concepts in health economics and evaluation, them being the concept of opportunity cost, the concept of marginal analysis, and the concept of benefit. Opportunity cost is the benefit that you forego when you choose an intervention over another. And here there's a very simple example where, let's say you have 10 crowns, and with those 10 crowns, you can buy a banana or you can buy a piece of chocolate. So by choosing the banana because you want to be healthy, then you're foregoing the benefits that you would get from buying the chocolate. So this is your opportunity cost, is the benefits that you forego had you bought the chocolate. And this can be applied to healthcare. And why is there an opportunity cost and why is there a need for choice? Is because, again, scarce resources. It's just not possible given the limited available resources to just finance everything. Another concept is the concept of marginal analysis, and this allows you to then determine the point is called the efficient point, where you get the most benefits for the resources invested. And you need to find that efficient point where it's not worth for you to invest more resources, more money to get a certain outcome, because you're not going to get more benefits, more outcomes for the resources that you're investing. So marginal analysis allows you then to determine the additional cost that you need to pay to get an additional unit of benefit. And this is also what economic evaluation aims to do. And the concept of benefit, this is what you're trying to maximize. And different forms of evaluation adopt different approaches to measure benefit. And let's look here at this example. This is a table where there's the three main types of full economic evaluation. There could be also other two here in this table, but I've chosen to focus only on the most common ones. And you see that, so cost effectiveness analysis, cost utility analysis, cost benefit analysis, they all value costs in money. What differs here is how they value consequences, with cost effectiveness analysis valuing consequences as single clinical outcomes, such as blood pressure points, life years gained, cases of depression avoided, etc. In a cost utility analysis, they use outcomes such as QALY or DALY. So they use generic outcomes that include different dimensions. And in cost benefit analysis, they value outcomes as money. And then I would like to briefly talk to you about the difference between trial-based studies and model-based studies. And in trial-based studies, let's say we have a study population that is randomized to either an intervention or a comparator, and there's a bunch of measures about that population that are taken at baseline, and then at follow-up, and we estimate then the changes in, you compare the results and estimate the changes in both resource use, costs, and outcomes between the two groups before and after. And you draw your conclusions. In model-based studies, let's say you might or might not depart from information that was gathered from a trial study, but you're limited to the time horizon that that trial actually had. So then you can go and get information from the literature, for example, from register studies. You can make a bunch of assumptions and you try to estimate then the future outcomes and future resource use and costs over different time horizons. It could be a 1-year time horizon, a 2-year time horizon, or even a lifetime. And then again, you compare the outcomes and the costs between those two groups over time. So now we're going to talk briefly about the economic burden of mental health problems in general. And a burden of disease study has estimated that, looked at the burden of disease in terms of disability adjusted life years. This is an outcome measure of disease burden that includes both morbidity and mortality. Morbidity, for instance, in terms of prevalence, and mortality in terms of number of deaths. This is the burden of disease for Sweden for both sexes, all ages per 100,000. And we can see here that mental disorders, the burden of mental disorders, is in 4th place. So in the 1990s, but also still today. So this is the ranking in 2019. So it's in 4th place in terms of the total burden of, or in terms of the proportion of the burden of disease that it amounts to, that it's responsible for. And then to your right below, at the lower bottom of the figure of the slide, you can see here, this is just a little snapshot of part of a table from a report from the Institute of Health Economics, where they've estimated the total cost burden of different disease groups in Sweden for the year 2017. And it estimated a total cost, so the total burden of disease for Sweden was estimated in about 872 billion Swedish crowns. And in this total cost, they included direct costs due to healthcare resources and indirect costs due to productivity losses. And they were able to see that mental disorders, see here at the first line in your figure, mental disorders amounted for 24% of the total disease cost burden of 872 million Swedish crowns. So 24% of that. And it had increased from 15% in 75 to 24% in 2017. Of those costs accruing to mental disorders, 38% were due to productivity losses, so to indirect costs. When it comes to mental health problems in children, it is, so based on the literature, there's evidence that mental health problems actually lead to severe consequences, both in the short and the longer term, in terms of poor performance in school, unemployment and low earnings, substance abuse, crime, and psychosocial problems. And mental disorders are ranked as #1 cause of disease burden in Western Europe. So just one step before we go to that, another important information is that also evidence shows that starting at an early age, 50% of everyone that will suffer from mental ill health will have early signs of mental health problems or symptoms before the age of 14. And given then all these consequences, the morbidity associated with these consequences, the disability, and also the high costs associated with these consequences, and the ability of investing early, given that children show signs at an early age, this actually makes a good case for investing in effective early interventions for children, given that they may have impacts in both the shorter term and the longer term. And in the longer term, not only gains in health and health and quality of life could be observed, but also savings in terms of resources related to those consequences that I pointed out. So with this in mind, I'm bringing to you 3 examples of studies that we've conducted. So if we start first with the trial-based economic evaluation, and this is the only example that is not yet published. So these are preliminary results. The paper is being submitted. And this study has looked at the cost effectiveness of internet-delivered psychotherapy compared to in-person psychotherapy for obsessive compulsive disorder in children and adolescents. And a little rationale here, why looking at why obsessive compulsive disorder. And it is known that young people with OCD have limited access to specialists in-person CBT. And in-person CBT stands for cognitive behavioral therapy. Is actually recommended as first-line treatment for mild to moderate OCD. And if we could improve then access to treatment, and here access to treatment if it were able to be delivered via the internet, and then if children and adolescents would not respond to treatment, then we could offer then the face-to-face option. Then we could reach more people and have better outcomes for this group of patients. And OCD has about a 2% prevalence in the population, and it has severe morbidity and mortality associated. So increased risk of mortality and also increased morbidity in terms of the functional impairment that is associated with, and also other comorbidities such as anxiety, for instance. So this was an economic evaluation embedded in a non-inferiority trial. So we wanted to show that this stepped care approach, internet-based plus then face-to-face for non-responders, compared to face-to-face, was equally as good. So worked as well and was, in this case, we want to show that it was less costly. So we randomized then 152 children and adolescents aged 8 to 17, either to internet CBT or face-to-face. Those that did not respond to internet CBT, so the non-responders, were then offered face-to-face, and then we assessed whether they responded to treatment here after being offered the full stepped care version. In terms of methods, we had the main outcome was response to treatment defined on a specific scale for obsessive compulsive disorder called the SIBOX, Children Yale Brown Obsessive Compulsive Scale. And then we also looked at QALYs over time using the Child Health Utilities 9 dimensions. And this is a preference-based instrument such as the EQ5D, for example, that looks at 9 dimensions in children's that could impact children's quality of life, and then being whether the child is worried, sad, in pain, tired, annoyed, how well performs schoolwork, how well the child sleeps, performing daily routines and activities. It's self-report. And then there were assessments at baseline, post-treatment, 3 and 6 months follow-up. So resource use and costs were collected using a questionnaire. And we had 3 costing perspectives: the provider as payer, and here healthcare provider as the main payer. So we included intervention cost, and then a healthcare perspective where we additionally included healthcare resources for children, such as whether the child saw a psychologist or a psychiatrist, etc. We included over-the-counter medication, so prescribed medication and over-the-counter medication. And then, this is the third perspective. We additionally included social support and assistance. There being, so examples, special teachers, special assistants, host family, study buddy, and productivity losses related to absence and efficiency at school for children, and absence and efficiency from paid and unpaid work for parents. So what do the results show? They show then that, so basically, that there were no differences in treatment response or in quality gains between the two groups. And that the intervention was actually, the stepped care was significantly cheaper from the three different perspectives. So this actually shows that stepped care was as effective and cost effective compared to face-to-face. And here, briefly, we see the cost effectiveness acceptability curves that show the incremental benefits on the x-axis and the incremental costs on the y-axis for the response to treatment outcome, and the qualities for the different perspectives. And we see here that, well, it's showing the results in terms of so lower costs and the effects being here in the two quadrants between, so less effects and more effects. One of the limitations is that there's the time horizon was quite short, and we didn't take into account possible impacts on siblings, for instance. Another study is a modeling study where we looked at the cost effectiveness of different parenting interventions for child behavior problems. And here we built a multiple cohort Markov model that modeled about 944 children that had received one of 5 different programs or a book. We projected the outcomes and costs of these children from the age 5 to 12 until they became 18 years of age. Based on data from an RCT, a randomized trial, we were able to assign disability weights to the different proportions of problems that these children had and calculate disability adjusted life years. We included costs here from a healthcare perspective and an educational sector perspective. Here, disability adjusted life years as the result from years of life lost. In this case, mortality was considered 0, and years lived with disability. And this was what we considered, where we multiplied the prevalence of problems times the disability weight that we got from the literature. So most of the data inputs came from the literature and this baseline RCT that gave us a lot of epidemiological data. And the model here, we can see the pathway that children would do from being below a clinical cutoff of problems to then developing problems. And here we considered attention deficit, hyperactivity problems, conduct problems, and comorbid problems. And then the different epidemiological pathways, including incidence, remission, and case fatality, and all-cause mortality. So this model simulated then these different cohorts of children that moved between the different states, and we try to estimate then the impact of the intervention on the prevalence of these problems. So what do the results show? They show that the book and COPE was one group-based face-to-face program. So both the book and this face-to-face program called COPE dominated all the other interventions, meaning they were cheaper and gave better effects. The book was the cheapest, cost about $14 per participant. And then we estimated an incremental cost effectiveness ratio of COPE versus the book, and we got about $2,600. What does this mean? That the self-help book is the least costly option, and if you would want to invest then in a program that gave more effects, you would have to pay this much, $2,600, to get more effects. We can move on to the last study, being mindful of time. Then this was a cost of illness study where we aim to estimate the additional healthcare usage and related costs in mid-adulthood for individuals that were diagnosed with depression in their adolescent years. We used here a cohort called the Uppsala Longitudinal Adolescent Depression Study. Adolescents were diagnosed then with depression at age 16 to 17, and then we estimated the consumption of resource use and the related costs until they were 19 to 30. So to estimate this resource use, we included inpatient care, outpatient care, and medication. And what we did was that we then compared those individuals that were diagnosed with depression with those individuals that were not diagnosed with depression. And we matched them using propensity score matching so that we could get groups as comparable as possible for our analysis. So here is our study population. So we have a bunch of those that were not depressed, and then the remaining that had depression actually had subthreshold depression. Others had major episodic depression, and others had persistent depressive disorder. So the results, we could observe that females in particular, those with persistent depressive disorder, utilize significantly more healthcare resources in mid-adulthood. And here we're talking about significantly more inpatient care, significantly more outpatient care, and significantly more prescribed medication. In this case, antidepressants. So we were able to see then that depression was associated with increased resource use and expenditure, more pronounced in persistent depressive disorders and in females. And then we made an estimation for the Swedish population, and we estimated then that the total annual cost for just one single age group of females with these persistent depressive disorders was about $3 million US. Yeah, so basically the same conclusions that we just talked about that focus actually on the importance of early prevention and treatment as priority areas. So to finalize, I would like to leave you here with a couple of methodological issues in the field of mental health that we can start our discussion with. And here being the problem with actually estimating relevant costs, how hard it is to actually get access to good and enough information that are related to major cost drivers for the mental health problems that we're analyzing. And then the importance of having the right outcomes and also including not only clinical outcomes, but also preference-based measures that allow us to get utility outcomes. So the importance of using the right instruments for the population that you're analyzing, the importance also of including spillover effects, so impacts on other family members other than parents and children, but also siblings, peers at school. And finally, also the importance of having the right time horizon that allows us to estimate costs and outcomes that reflect the full image or the full impacts of an intervention. And often impacts occur longer down in the future and not in the shorter term. So hence important also to do modeling exercises to try to get those estimates of costs and outcomes over the longer term. And that's all I wanted to say. I went a little over time, but I'd like to thank you all for listening to me, and I give you the word, Camilla.
Thank you very much, Filipa, for the very interesting presentation. Let's jump to the questions already. We have a few questions. One is from a KI alumna. Thank you for the fantastic presentation. She started her PhD at the German Center for Neurodegenerative Diseases, focusing on patient preferences for person-centered care among people with dementia in comparison with physicians' preferences. The question is, do you have knowledge about potential applications of stated patient preferences methodology, like multi-criteria decision analysis for child mental health treatment and care?
Well, there are a few multi-criteria decision tools, but I'm not sure I don't think they are particular, at least those that I'm aware of. I'm not sure they are particular to child mental health. So maybe there are more underway. I don't know if whoever asked the question, if they're aware of other instruments in the area?
Well, maybe she can write another comment. We can wait. Well, for now, we have another question asking about mental health research centers at Uppsala besides Uppsala University. Are there any collaborations outside Sweden?
Collaborations
Related
so that we might have with other research groups out of Sweden, is that the question?
Yes.
We have a few collaborations, some of them within Sweden. So we have with Örebro and the university, with Umeå University, and also our collaboration with Karolinska. We do a lot of trial-based economic evaluations based on their trial data. Internationally, we do have some collaboration with the Deakin University in Melbourne. We've done a couple of studies together. They have a big research unit focusing on mental health economics. We also have a collaboration with, it's a researcher called Jeffrey Hodge from UC Davis in the US. So I know he's also been collaborating on a study with a colleague, and he's contributing to the methodology in another of our papers. But his focus is not mental health, is more method development. But I could, of course, give tips on other research groups that focus on mental health research if there's an interest.
Thank you. Maybe we can provide your email if there are any further questions related to this.
Yeah, absolutely.
Great. There's another question. So you showed us a lot of methodological challenges for the research, and we were also wondering about, after the research is done, what about the implementation of those results at a service level? At what are the policy implications of those studies?
Of the ones we've conducted?
Yes.
That's a really good question. It takes time to go from research to policy and practice, actually, to make sure that your results are put into practice. And I would say, well, before actually giving one or two practical examples of the impact of our research in policy, it's really, really important to involve whoever you find important in the field. So the stakeholders that you've identified that are crucial for these results to be transferred into practice, it's important to involve them at an early stage in the evaluation. And if they fund the project, even better, because they will have an interest in knowing, how the money is being used. And if not, you can still contact them and try to get their perspectives in the work that you're doing, trying to understand, how to include, try to include their perspectives in the work. But I can give you an example of, for instance, a parenting intervention that was evaluated back in 2012 in Uppsala region, that after our evaluation efforts actually continued being financed by the region. And nowadays also a lot of, I would say most of the regions in Sweden, most of the regions actually offer parenting interventions, because there's so many studies showing that they are effective and cost effective to improve child mental health, parental mental health, reducing behavior problems. So I'd say that parenting interventions are a good example of how research was taken into practice. Right now, I cannot remember any other example, but I remember, so recently 2 reports were actually released from 2 colleagues in the group, and they had so together with two municipalities, I think it was Norrtälje and Botkyrka, they evaluated their public health interventions. So the public health interventions that they had in place in those two municipalities, and showed so their impacts in terms of health and resource use. And I think so. The report was just released, but I think so this information has given the municipalities more tools, not only to be able to evaluate themselves the work that they're doing, but also to understand, okay, what we're doing actually working? Should we do something else? Are we investing our money in the right interventions? So, but again, this was a collaboration with the municipalities from the very beginning. So yeah. So again, I think maybe the message is involve those that are responsible, the stakeholders, that are key, involve them from the very beginning to make sure that actually your results are going to be used to make improvements in practice.
Thank you. It's very good to know that there is this collaboration. So I think we don't have any further questions. Let's see. Well, I think that's it for now. So I would like to thank you everyone for watching and for asking good questions. We will host more events. So if you enjoyed this event, please check our Facebook on the events to follow. We will have events on topics such as nutrition economics, epidemiology of diabetes. We will host events on HOR with companies such as MedUniverse and PetFX. And we will also hear from a representative of the National Board of Health and Welfare in Sweden. So you can check all the details on our social media as it's here in the flyer. And the last thing, we are also recruiting new board members. If you have an interest in health economics and outcomes research and would like to join our team, we have several tasks that you can apply for. Just email us with your motivational letter and CV by March 19th. And thank you again, Filipa, for your great presentation. Any final words?
Thank you for having me.
All right. Thank you, everyone, for watching. Bye.
We'll be seeing you soon.
Yeah.